I'm gonna try.
Yeah, you're good. Yes.
Okay. I can't see you guys at all, and in order to do it, I have to exit out. So I'm just gonna, I guess, keep going.
Okay, go ahead.
Jeanette, I can't see you. Just I'm gonna start. Okay.
Okay.
Oh wait, you're gonna start. I'm sorry. Jeanette's gonna start. Just let me know when to go to the next.
Okay, hold on. Do you want me to just screen share? Because I think that's easier. Or you know what? I'll just I'm gonna pull the slides up myself.
Okay.
Okay, you can go to the next slide.
Okay.
Professor, I'm here. Hooray.
Oh, hi.
It's Amy.
Hi, Amy. Thank you.
Okay, HIV is an immune deficiency. It is the failure of the immune or inflammatory response to function normally, resulting in an increased susceptibility to infections. There are two categories to HIV. One would be the primary, which is more congenital, meaning it's caused by a genetic defect. And then the other is secondary, which is what we commonly see, which is an acquired immune deficiency. It's caused by another condition, such as cancer, and normal physiological changes such as aging. Acquired forms of immune deficiency are far more common than congenital, which is what we mostly see in patients these days. HIV immune deficiency virus is secondary. So HIV suppresses the immune system against itself and secondarily creates a generalized immune deficiency by suppressing the development of the immune response against other pathogens and opportunistic microorganisms. The virus affects and destroys the CD4 cells, which are necessary for the development of both B cells for humoral immunity and cytotoxic cells, which are for cellular immunity. There are two types of strains. It is HIV-1, which is most common, and there's HIV-2, and that one is transmitted in the same way, but it's less infectious. It progresses a lot more slowly than the HIV-1, and it's typically found in West Africa. The next slide. Okay. Bloodborne infection routes of transmission for the HIV virus would include blood-to-blood products, intravenous drug use, sexual activity, and mother-to-child transmission during the birth process. The pathogenesis for HIV HIV is a member of the virus family called retroviruses, and retroviruses are they're grouped based on how they're structured and how they replicate within the host, meaning the person infected. Carriers to two identical copies of single-stranded, my apologies, RNA rather than DNA. RNA runs along with the viral enzymes reverse I'm sorry, first I can't pronounce the word. Transcriptase, integrase, and protease is packed within the viral particle inside the capsid. The capsid is encased in an envelope which displays glycoprotein 120 on the surface connected to the transmembrane glycoprotein number 41. The next one.
Just let me know when it's mine. I'm sorry, I can't see anything, just the slides. I can't see.
It's yours, the
Okay.
symptoms.
All right, so I'm gonna start with symptoms. So they begin as flu-like symptoms, and within the 2 to 4 weeks, this is considered acute HIV infections. Symptoms may last for a few days or several weeks. Some people might not even feel sick at the acute HIV stage. They could have a fever, a rash, chills, night sweats, sores, sore throat. I'm sorry. I apologize, Professor.
Go ahead.
I'm sorry, I have my children home today, so apologize in advance for the inconvenience.
That's all right.
Okay, so like I said, these would be the symptoms. They can go from very mild to severe. And then there are also 3 stages of HIV. So stage 1 is when large amounts of HIV are in the blood and the person is very contagious. They might have flu-like symptoms, and this is the body's natural response to the infection. However, some may not feel sick at all. Only an antigen antibody test or a nucleic acid test, which is called the NAT, can diagnose the acute infection stage. And if you have flu-like symptoms, it's said that you think you've been exposed to HIV, seek medical attention and get tested for the acute infection as soon as possible. For stage 2, it's considered chronic HIV infection. It's also called asymptomatic HIV infection or clinical latency. So it's where the virus develops without producing any symptoms. The HIV is still active, but it produces at low levels. Without taking the medication. This period may last a decade or longer, but the virus may progress faster. HIV can be transmitted in this phase as well. At the end of the phase, the amount of HIV in the blood, which is called the viral load, goes up and the CD4 positive cell count goes down. As the virus level increases, the body may begin to have symptoms and they move into stage 3. But people who take their HIV medication as prescribed usually never move into stage 3. So stage 3 would be when they get their AIDS diagnosis. So it's the most severe phase of HIV. People with AIDS have very badly damaged immune system, so it places them at risk for severe illnesses called opportunistic infections. When the CD4 positive cell count drops below 200 cells, they develop a certain opportunistic infection, the patient major efforts. HIV and AIDS is still a major health concern. In 2007, 36.9 million people were living with HIV/AIDS, and 1.8 million of them were children. And about 70% live in the sub-Saharan African in middle and low income countries. And that's our PowerPoint.
Can you, Janet, can you just go to slide number 1?
Yeah, I think she mistakenly said that the HIV virus was primary and secondary. That was a mistake on my end when I explained it. So there is 2 versions of the HIV virus. So the HIV one is the one that our book mostly focuses on and what a lot of people are infected with. So they really don't talk too much about the HIV 2 because it is less common. But what Jeanette was saying in the beginning, again, that was my mistake, that we were just trying to explain what an immune deficiency meant and the 2 different kinds of immune deficiencies. So primary would be caused by a genetic defect, and the secondary is when you acquire it, meaning like you get it from somebody or from the outside world. It's something
right.
that
yeah, exactly. That's the immune deficiency, which is a constellation of different diseases, including the HIV/AIDS. So
yes.
the HIV/AIDS is always is always classified and identified as a secondary. Yes, exactly. So it's
Yes.
not genetic, doesn't have any, genetic predisposition. It's
Mhm.
always has to be infected from somebody else, right? Or there is a mode of transmission, either bloodborne, sexual contact. That is the mode of transmission for the HIV. It's always acquired secondary. So it's not, primary. So the first slide is just explaining the different types of, right? Yeah, exactly. Yeah. So just to
explaining the
clarify.
different types of immunity and different type of immune deficiency.
Good.
Again, that was my mistake when I explained. I apologize.
No, that's fine. That's good. Excellent. All right. So perfect. Good job.
Thank you.
Yeah, good job. Perfect. So let's, okay. So any questions for
Coco, I'm in class. Go.
Janet or Delilah? Okay, so our,
Question. I have a
yes,
question.
go ahead.
Do you guys know like what places in like the US have the most HIV rates? Like what cities?
In the book, it doesn't say exactly how. It just says about an estimated of 1.1 million people in the United States were reported to be living with HIV, but that was at the end of 2015. So, wait, I'm sorry. So we haven't gotten to the current to 2020.
Okay.
All right, so we'll go to the immunity. See when you do the presentation, how it's frustrating to, the technology is. It's much easier to have a face-to-face, class and just lecture in class, better than just all this online courses. It's at some point frustrating, technology is good when it works, but when it's, sometimes we have a lot of challenges. We encounter a lot of problems and issues with technology. I know it is, but this is just give you an example how frustrating it is, when you teach online.
It's frustrating all the time, Professor.
Right, for everyone. I mean, I know
Yes.
for you, for us, yeah, it's much easier to teach in class and just face to face, much easier. Okay, so let's see our attendance before we go further.
While you're doing that, Professor, I just wanted to say if people want to know more about like where HIV, where the diagnoses are greater and stuff like that, the CDC has a statistics center.
Exactly.
And they break it down. So they have the highest rates of new HIV diagnoses were mainly in the South, and it's Florida, Louisiana, and whatever the
So yeah, CDC is the best resource and reference to look up, all this information, detailed information about, it's more for, for people's, literacy, kind of, health, literacy, so they would know everything about any disease, especially, the infectious diseases, how, even protocols, policies, how to teach, patients or patient teaching, education. It's about also give you the, the prevalence, give you the all the rates of the epidemiology, rates. It's all in, under the CDC website. Thank you, Amy, for this information. Yeah, that's the best resource. There's a lot of other resources, but the CDC is the best and the most actually trusted too, because that's, it's rigorous, it's scientific, it's national government, government, control, also unfunded too by the government. So the lecture today, as I see here, that we condensed the slides to less than 100 slides for all 4 chapters: chapter 6, 7, 8, and 9. So this is the content that you need for all, for the immune system or the immunity at 3 levels and for the 4 chapters. You can go and expand on the, from the book and, as you study from the book, don't go beyond what we have in the PowerPoint slides. We have a lot of information, very comprehensive, and you go like in width and depth for the info or the knowledge for these 4 chapters. So don't go beyond. These are your boundaries. This is your like landmarks. This is your, I would say, framework to take it, the content from the PowerPoint to study from the book. So any other questions before we go to, we begin with the immune system? So good that we, the HIV is that, that also belong to the, to the content we have today, which is the immune system. So we talk about here about the defense mechanisms. So the 3 areas, which is last 2 weeks, we spent about 3-4 lectures on fluids, electrolytes, and ABGs. Today, immune system, and then next week we will cover or talk and discuss the cancer or neoplasm. So these 3 areas or 3 content areas, it forms or considered as the foundation, as the background, or you can lay the foundation for the pathophysiology. And then we'll move on to the systems. A neurologic system, cardiovascular system, pulmonary system. So systems will begin after the neoplasm or cancer lecture next week. So these are the 3 main content areas that will be considered as the foundation and conceptual foundation for and concepts for the pathophysiology. So let's begin with the first slide, which talks about the lines of defense. So we have physiologic line of defense, which is the first line of defense, which is we call it the inner or the internal resistance. So the inner resistance, which is the first line of defense, that's something given to us, like physical and mechanical barriers. And I have lots of examples. I compiled the examples from our textbook and from other, resources. We have biochemical barriers, and we have lots of examples too. So I'm not going to read everything, word by word from the slide. It's just to highlight some of the difficult concepts and mechanisms. There are some complex mechanisms need to be, simplified, need to be explained. So we don't have, I don't think we have enough time to go over word by word. So the easy stuff, I leave it for you to to read it, and then I will just highlight the most difficult, the difficult and sophisticated, and complex concepts and mechanisms. So the first line of defense is things that given to us. It's ingrained, or things that was.
Professor,
yes.
Are you sharing the screen? I'm not seeing.
I believe I have. 1 second.
You don't see the slide.
Can I just take the attendance share screen? Yeah, now I think we should be fine, right? Can you see the screen now?
Yes.
Okay. Okay. So the first line of defense, we said it's the examples of that would be the physical and mechanical barriers and biochemical barriers. I'll give a few examples about each one underneath each one. Now the second line of defense, which is the inflammatory response, the inflammation when we when our body or the system develop the inflammatory response, that is second line of defense. And then the third line of defense would be the adaptive immunity and the different types of immunity, and we will go over that. And that would be the HIV/AIDS will be listed as one of the diseases under the third line of defense, which is the acquired immunodeficiency disease. So second slide talks about the inflammatory response. So here the slide talks about the stages or phases of the inflammatory response, and the inflammation. Well, I think in Adult Health 1, I believe that you cover inflammation and inflammatory response in terms of signs and symptoms and what the cardinal signs of manifestations. So what are the like the hallmark manifestations of inflammatory response or inflammation?
Swelling,
Redness, yeah. Mm-hmm.
swelling,
Redness, hotness, which is warmth, edema, right? Pain, tenderness, restriction of the organ or of the extremity, if that affects the body part that became like difficult to move or difficult to use. So the inflammatory response, here you see the blood vessels, and there is the permeability of the wall of the blood vessel becomes more permeable to leak fluids, so that will result in leaking some fluids out of the blood vessels. That's why the area will be swollen. The neutrophils will be gushed into the. One second. These are some just benefits of the inflammation. So the two major stages or main stages of the inflammatory response. During the acute inflammation, the vascular phase, which results in a movement of plasma into the interstitial space, causing the edema. So because of the blood vessels dilate, so causing vasodilatation, and the blood vessels become more permeable to fluids or to content. So increased vascular permeability result in the edema and the warmth and the redness. And then the white blood cells also, the neutrophils or white blood cells, will adhere to the wall. And we'll talk about that, about this, step later on. Second phase, which is cellular, which is that the inflammatory cells release the histamine and bradykinin. So these are the chemical, we call them, or these histamine and bradykinin, we call them chemical mediators, because these are the chemical substances or molecules will be released from the mast cell to increase the permeability of the blood vessels. They make what make the blood vessels more permeable to leak the fluids out of the blood vessels to the interstitial space and cause the edema. White blood cells and platelets move toward the damaged cell, which is what is called phagocytosis, to engulf the invading organism. Can be invading, particle or substance, or can be any object, including microorganisms. So these are some of the chemical mediators or chemicals that will be released from the mast cell to create what is called the increased permeability of the blood vessels and result in leaking of all the fluids out of some fluids out of the blood vessels. So the inflammatory response begins or starts from what is called the mast cell. Mast cell. So the mast cell, it's a small, like bags, cellular bags, granules. They are located in the connective tissue. And they are always very close to the blood vessels. That's why they have immediate an effect on the blood vessels and the increased permeability to the fluid to move out of blood vessels, because they increase the permeability of the vessels. So they are present and or you will find we can find these mast cells in the skin, digestive lining, respiratory tract. That's why you will see the effect of the inflammation result in the like patients with COPD, for example, or patients with asthma. They'll have lots of secretions, chronic bronchitis. They'll have secretions coming out of, in the pulmonary tree or pulmonary, bronchioles, because of the mast cells will affect the blood vessels and increase the secretions. And then patients with pulmonary disease, they will have lots of secretions. The stimuli activate the mast cell to release its potent soluble inducers. In this case, we call them chemical mediators. So the mast cell this is one of the difficult pieces of the immune system when it comes to the inflammation and the process of the inflammation, or the mechanism how the inflammation occurs, or the pathophysiology of the inflammatory response. That's the most difficult piece, which is how the mast cell is going to release these chemical mediators, and then it will have effect on the blood vessels. So it has vascular and cellular response. So two phases for the inflammation: vascular, and then another one is called cellular. So the mast cell will release all these chemical mediators, and that's would explain patients who would have the allergy, right? Because they take what would a patient with allergic, who had like seasonal allergy, what medication would recover or resolve the problem? They will go to the over-the-counter, to a pharmacy and get the over-the-counter medication. If you have an allergy, you would go to take what kind of medication would you be looking for?
Histamine?
Antiviral?
The antihistamine, not the histamine.
Antihistamine.
Yeah, we are looking for the antihistamine, because the histamine, see how is the histamine, the previous slide talks about the histamine and bradykinin, and they have specific effect on the physiological effect on the blood vessels. They cause vasodilatation, the histamine. With the vasodilatation and increased permeability of the blood vessels, it will result in more secretions, because more fluids will leak blood vessels, go to the interstitial space, and we will see more secretions. And that's why people who had like seasonal allergy, they will have runny nose, right? Tearing eyes. So all these secretions came from the histamine. And when they take the antihistamine, that will resolve, most likely going to resolve the problem. And that will, if you can write it down, something that relates also to the pills is that patients who are hypertensive, they are, at least we should educate them not to consume large amount of antihistamines, because the antihistamine is a vasoconstrictive. If the histamine is vasodilator, then the antihistamine will constrict the blood vessels, right? So it's a vasoconstrictive, the antihistamines. So patients with high blood pressure shouldn't be taking too much of that antihistamine. So that's something on the side, is just to remember when you get to your in the fall in farm, to remember this: the antihistamine and the increased blood pressure. So back to the inflammation and inflammatory response. So the mast cell is going to release the histamine and the other chemical mediators by two different mechanisms. The mast cell either will release it by what is called the degranulation, which is in this slide. We have two arms, or two mechanisms for the mast cell to release these chemical mediators, either through the degranulation, in which that the mast cell will release. Remember, these mast cells are very close to the blood vessels, so they will release the content, which is the antihistamine through granulation. I'm sorry, the histamine and the other factors right directly to the cells. or to blood vessels. So to have an immediate effect on the blood vessels. Another mechanism is that in which the mast cell will have an effect will result in inflammatory response by synthesizing and producing, which is synthesis of the chemical mediators like the prostaglandins, leukotrienes, platelet activating factor. So two different mechanisms, degranulation or synthesis. Degranulation, these vesicles, these granules will rupture and then will release its content, and it has immediate effect on the blood vessels like chemotactic factors, histamine. So the chemotactic factors, one of them is called NCF, neutrophil chemotactic factor, and we have ECF, eosinophil chemotactic factor. From the name, these factors are going to attract either the eosinophil or the neutrophils that are specialized to go and grab the neutrophils and bring it to the affected area from the bloodstream. They will travel to the bloodstream, get the neutrophils, and then bring it to travel to the affected area in which there is an inflammatory response. Because we need the neutrophils, we need the white blood cells. It's part of the inflammatory response. And as you read the benefits of the inflammation, it's a lot. There is a large, a whole number of benefits. We have lots of benefits of inflammation. So all these neutrophils will be traveling to the affected or the inflamed area. So the degranulation or synthesis, either way, we have chemotactic factors that's going to elicit and result in inflammatory response. It will make more sense when you get to we take the pharmacology, because the pharm or the pharmacology as a science is based on the pathophysiology. So let's take the antihistamine. It's based on the science of the effect of the mechanism how histamine works. Same thing for patients with asthmatic attack or patients with COPD. They take a medication. One of the meds, for example, called montelukast, which is singular, which works on exactly this leukotriene. See this leukotriene? This is one of the chemical mediators that will be synthesized from the mast cell. So that drug is called leukotriene modifier. So it works against antagonist to the leukotriene in order to stop the inflammatory response and the effects of the inflammation. So the patient with the COPD or patient with asthma, they will benefit from this leukotriene modifier, which is like antagonizing the leukotriene. So these are the chemical mediators that they will activate, and they will heighten or will be involved in the inflammatory response. The histamine, the NCF, the ECF, and then on the other side, the synthesized ones like the prostaglandins, the leukotrienes. And then I listed here some of the effects of each one, like what leukotriene would do, or the action of leukotrienes, the prostaglandins, and we have too many types of prostaglandins. Then we have the phagocytoses. That's the cellular component of the inflammation, in which the neutrophils will be attracted from the bloodstream to migrate or to travel to the area of inflammation. So we will have people to fight the inflammation, like the neutrophils. Mostly will be neutrophils, which is the major part of the white blood cells. And then here we have the steps for the what is called diabetes, which is the migration of the blood of the neutrophils from the bloodstream or from blood vessels, and then leaking to the inflammation site. Here is just listing also the description for each one and the function for each type, like neutrophils. The majority of the white blood cells should be of a neutrophil type. That's the most effective one, and that's the first leukocyte to arrive to the to the inflammatory site. When I have inflammation, the first one to travel from the bloodstream to, or from plasma to the inflammatory site is the neutrophils. And we have monocyte macrophages, and we have eosinophils, and eosinophils would be more of have a significant effect on the parasites. So anytime people are infected by a parasite, the eosinophil count will rise extremely, will go up, and that's because it's the most effective white blood cell against parasites. Basophils, the natural killer cells, and the platelets. And now we have the cytokines. The cytokines, which is the cellular products, like interleukins, interferons, and the interleukins, they are produced primarily by macrophages and lymphocytes in response to pathogen or stimulation by other products of inflammation. So during that mast cell activation, you will see also interleukins, interferons, also part of the what is called the cytokines. And we have different types. TNF, tumor necrosis factor, another one. And when for example, the fever will be induced would be induced by the TNF, for example. It also can cause the wasting of the muscles, in which it will result in what is called cachexia. Cachexia, which is the excessive, when you say patient is cachectic, means patient is like skin and bone. Cachexia. So that's when the patient lose a lot of weight, and that's especially in cases like patients with infection or severe infection or with cancer, they lose a lot of weight, and that's called cachexia, or patient is cachectic, means patient is like skin and bone, has lost a lot of weight. So these are responsible for increasing that the temperature, weight loss, or the muscle wasting. So the local response or the clinical manifestations of the inflammation, we have local manifestations, and we have a systemic manifestations. So the local manifestations, that's mostly will result from the leakage of fluids, like exudate. We call it exudate, which is when the fluids leak blood vessels and exit and leaks to the interstitial space. That will be fibrinous exudate. Purulent. Whenever you say purulent, always it's pussy, means there's a lot of pus in it, which the pus is is composed of most of bacteria, dead bacteria, and other tissues. So that will be, and platelets and blood clots, but that's called purulent exudate. That's when you have like a pus drainage from like a cyst or from infected area, in addition to the RBCs and blood and so forth. So that's exudate fluid. And we know edema, that will result from the inflammation, and that's due to the increased pressure in vessels. And the transudate, which is leakage of fluid from the blood vessels. So we have exudate, transudate, purulent exudate or purulent, which is pus drainage of composed or consistent pus. Um, so the manifestation and the causes of each one of the inflammatory process and its manifestations. For example, when we say redness, why a patient didn't develop, a redness of if they say that for forearm trauma resulted in a redness, and that's because of the hyperemia from the vasodilatation. And who would cause this? So it's in response to the histamine, right? And the other chemical mediators. What about the heat? It's because of the increased metabolism. The pain also, let's see, because the edema, swelling, and the edema that is going to press against the nerve, and that result of stimulation of the nerve by the chemicals and changing the pH, and from the leakage of the fluid. So the fluid exudates. So all of these together, nerve stimulation, changing the pH, and the fluid accumulation or leakage, and then accumulates and presses on the nerve, result in pain. Swelling, shift of interstitial and exudate. So that's results in the edema, and then the loss of function, which is from the swelling and pain, result in loss of function. So these are, how would you explain each of the inflammatory responses or the manifestations of inflammation in terms of the pathophysiological perspective, or or concepts that pertains to the pathophysiology. And these are some of the systemic responses: fever, leukocytosis, which is the elevation or decreased white blood cells, increase or decrease.
Decrease? I don't know, increase.
Like when you see cytosis, always increased.
Increase, yeah.
Increase always.
Lysis
Yeah.
is decrease, yeah.
Yeah, cytosis always increase. The penia is the decreased. Like leukopenia is decreased white blood cells. Leukocytosis, which is the increased white blood cells. So that's what would that's what would, when you expect patient with with inflammation and infection to have an increased white blood cells. That's the leukocytosis. And then fever, and then yeah, the leukocytosis here, and right in the bottom of the slide it says any white blood cell number or count over 11,000. So here it explains the mechanism why patients with infection and inflammatory response, especially an infection, they develop the heat and the fever. So they become febrile, and this is the mechanism, which is the body temperature is usually regulated by the hypothalamus. So it says here that some bacteria release the biochemicals, and it will be released into the bloodstream. And this will be considered as exogenous pyrogens. So in here, the word pyrogen means the substance that is going to increase the temperature. So it's exogenous pyrogen because that's the toxins from the bacteria, which is in this case it's the lipopolysaccharides, are mostly gram-negative bacteria, which will stimulate and signal white blood cells, mostly macrophages and monocytes, to produce their own biochemicals. They will encourage them, like macrophages, to produce what is called the endogenous pyrogens, which is why we call them cytokines. So these cytokines, like interleukins, interferons, will be produced in response to the effect of the bacteria. So bacteria produces toxins, that's exogenous pyrogens, stimulating the macrophages and monocytes to produce its biochemicals. They have the macrophages and monocytes, they have their own cytokines contained in the cells, like the interferons and the interleukins. So the toxins from bacteria will stimulate these macrophages to produce and to release the cytokines or interleukins and interferons. and some interferon. We said that the interferon that would, the temperature would increase in response to the interferon. And that eventually is going to release the prostaglandins, and then it will cause the hypothalamus to raise its set point. So the prostaglandin mostly, it has, so if we say that, interferon or interleukins, but the prostaglandin is the cytokine that is responsible for the elevation of the temperature, or to set the to change the set point for the hypothalamus, and then the temperature will result. The fever would result. So the fever actually eventually is going to result from changing the hypothalamus, its set point, in response to the presence of the prostaglandins. So the sequence is going to be bacteria, toxins, which is lipopolysaccharides. Toxins as exogenous pyrogenes will stimulate and signal the white blood cells, mostly the macrophages and monocytes, who contain the interleukins and interferons, to be released, and it will stimulate the prostaglandin, so the prostaglandin is going to cause the hypothalamus to raise its set point. So that's the mechanism of fever, in response to the mostly infectious diseases and the presence of the bacteria. And in inflammation, we have two factors will be elevated at all times. Like any type of inflammation, which is non-diagnostic, is very difficult to diagnose or differential diagnose from these two elevated elements or factors. These two are the ESR, erythrocyte sedimentation rate, and the CRP, C-reactive protein. So given the the previous mechanisms, you will find that these two will be elevated, and in response to any inflammation, but doesn't pinpoint exactly and tell you where is the inflammation. But when you analyze or send the blood specimen to the lab, and you get requesting for the CRP or ESR, they will always be elevated and during the inflammation or inflammatory period, response, but they doesn't specify which part of the body is inflamed, or organ or tissue, or so the ESR and the CRP will be elevated. The inflammation, we will spend, I think, in enough time or sufficient time in Adult Health 1 discussing the inflammation in terms of acute versus chronic, and the manifestations, and the complications that would result from the defective healing of the tissue. So active versus chronic, and the resolution or the healing process, the healing of the tissue would heal either by primary intention or secondary intention. Have you got to this point in Adult Health 1 or not yet? Yeah, I believe that they cover this in Adult Health 1, which is about the primary versus the secondary intention, in terms of that the mechanism how the tissue would heal. So for example, if there is like paper cut wound or surgical wound, these type of wounds will heal by primary intention. And imagine, so compare this one, primary intention, with a secondary intention, like a wound that is stage 4 pressure ulcer wound, sacral wound. You see how that one heals, and then the primary one, the paper cut or the surgical wound, would heal. Eventually, given the mechanism, the pathophysiology of the healing process, or the pathophysiological changes to towards the healing, you will find that the secondary healing, it will result in scar tissue more than what you would anticipate, and wound that would heal from the primary intention. Primary intention paper cut, you will never even when you have that healed, you can't even find out where what did you have the paper cut. Like you cannot even look at it. I mean, in terms of like scar tissue, zero scar tissue at some of these and primary intention. Same thing, surgical wound. If great sutures, and so it can also result in no scar tissue at all. But with the secondary intention is always a scar tissue, given the pathophysiology of the healing process. Some of the factors that may prolong the healing process, and that's very important for for nurses to know what are the things that we can implement or use or adopt to accelerate and to enhance in and knowing some would prolong the healing process. So some of the we're trying to avoid these factors that may prolong the healing process. So some of them here are not included in terms of like medications, for example. Very significant in terms of meds, such as steroids. Patients on steroids, the steroids will prolong the healing process. It will delay the healing process. Steroids. In addition to the hypoproteinemia, so that's why the one of the protocols in most of health practitioners, they recommend that people with any type of wound, they take enough or high protein diet, because the protein is considered as major or integral or significant factors to enhance the healing process. In addition to the vitamin C. So these are the dysfunctions of wound healing. You'll not necessarily that all patients when they have when their wound healed, then they will experience this. But these are some of the problems that may anticipate for some patients. Something called keloid scar or hypertrophic scar, and you will learn. I'm sure that it's all of this will be covered in Adult Health 1. Dehiscence, or when the wound get infected. And the last thing about the other complications from the just to add one thing to here to the complications from that like the healing process, that the contractures, especially who would experience this, the contractures after the healing process is kind of completed and the wound is healed completely. Yeah, these contractures will be more evident in cases like burn cases. Yeah, and mostly would result from, I would say, poor management or poor nursing care, and I mean the healthcare plan wasn't followed, in the right way, or wasn't like implemented correctly. So especially with the PT and OT, physical therapy and occupational therapy. So the interdisciplinary team, including nursing and OT and PT, and so it's in there is a problem with that. So or it's incomplete, or patient didn't have access to maybe rehab, for example, or but this is something you would anticipate in from the poor management of burn cases, the contractures. The last concept and infections, or in this chapter, which is talks about the shift at the white blood cells. As we analyze and do the interpretation of the results of the white blood cells, the leukocytes, there's something called bands and segs, two different types of white blood cells. segmented segs or segmented, and the other one is bands. So the bands should not exceed the 3 to 6%. That's the maximum of, because as we when you read the results of the white blood cells, it said white blood cells or leukocytes, and then we have the neutrophils and the eosinophils, the monocytes, and then you get to the segmented or segs and the bands. The bands are the immature white blood cells. So just to try to highlight this concept that the bands, it's part or the type of white blood cells, leukocyte, but it's the immature white blood cell. So we don't need too much of this immature white blood cells in the blood because they are inactive. They doesn't have any activity. So they are immature. They are mature enough to elicit the inflammation. So these bands should not exceed the 6%. When would you expect that the bands will be exceeding the 6%? That's during the infection, sepsis or infection. Because the bone marrow, as a compensation, will attempt to produce, in response to the infection, to produce large amount of white blood cells. And because of the fast production, so it's like accelerated production, it will produce immature cells like these bands. So we'll have large amount of bands. So when you see a high percentage of bands in the blood, in the white blood cells or among the white blood cells, as a percentage more than or over 6%, that reflects that there is an infection or sepsis. And this is what is called, so when you see something like that, it's called the shift to the left phenomena or concept. So it's based on shift to the left phenomena. It's based on the presence of high percentage of bands, immature cells or white blood cells among the white blood cells. So white blood cells, if that's 5 to 10 or 11,000, the bands should not account for more than 6%. If you see a bands over 6%, like the underneath, the patient with the bands of 10%, that's a shift to the left phenomena. Okay, so next topic talks about the immune system, normal immune response, which is the second line of defense. Third line of defense. First line, natural, innate immunity. Second line, it's the inflammation. So the inflammation, it's a form of immunity. So it's a form of protective mechanism. And then the third line of defense mechanism would be the immune or acquired immunity or the immune system, adaptive immunity. Either passive or acquired. We'll talk about the different types of immunity in a minute. So the immunity, so the adaptive, I know that the book talks about there's a lot of information and a coverage about and content on the immune system, and so let's just stick to what we have in the on the slides as a framework for for your study. If you want to study from the book, just try to limit yourself to this kind of a framework or content in the PowerPoint slides, not to go further or deeper in terms of discussions, because we have a lot of information and content in the book about all the chapters, not just this one, but this is the one of the kind of difficult topics in the immune system. So the immune system has certain features that is different than the other systems, right? So one of the first features of the system that it has, there's antigens that are going to be recognized by the immune system. So the immune system is one of the most intelligent systems in our body. It's going to find out who is the invader, who is foreign bodies, who is invaders, who is going to attack our body, and is going to react. So the antigens will be recognized as a non-self. And this is one of the most important concepts in the immune system. To understand the immune system concepts, this is the first one. Anything that is recognized by the immune system as non-self is going to be, which is antigen in this case, is going to be recognized as foreign body, the immune system will elicit the reaction or response to attack it. Second concept in the immune system, it is very specific. Each cell has its own function, and it doesn't go beyond or exceed it. It will go within the functions of each cell. Like we have T cells, we have lymphocytes. These are the integral, major cells, and that will form what is called the immune system. Lymphocytes. Two different types of lymphocytes. We have the B cells, B lymphocytes, and the T cells, the T lymphocytes. And by the way, they are a form of also of white blood cells too. So the lymph, so the lymphocytes B or T, they are part or a form of white blood cells. So they're specific. The B cells have a specific function. T cells, they have also specific functions. Third feature is that the memory. The immune system is the only system that has a memory cells. They are they are floating and they are present, and once they are formed, memory T memory cells, B memory cells, they are present when they are specific. They have a specific function. They're being specialized to attack, an X antigen, and they will be present in the lymphatic system and in our body to do what is called surveillance. So they will be present and do like surveillance. And so any second there is they find that specific antigen and they will elicit the immune response. Inducibility, which is that there should be an antigen that will elicit the immune response and that will induce the immune response. And then antibodies and lymphocytes. So these are antibodies which will be produced by what is called the B lymphocytes. The B cells produce antibodies. The T cells don't produce any antibodies. The antibodies, or what is the other name for the antibodies? If you don't see, when I say antibodies, you would call them immunoglobulins. Immunoglobulins, which is IG, like IgA, IgM, IgE, IgD. These are the immune globulins. So they are immune globulins or antibodies. They are produced from the B lymphocyte or B cells. So these are some of the functions of the adaptive immunity, is that we talked about the defense, about the homeostasis, surveillance. So these are like functions, three main functions for the system. And there are different phases. Well, I'm not going over the phases. There's a phase called clonal diversity. That's a little advanced. And there's another one called clonal selection. And that's, again, it's kind of, advanced, patho. But just let's stick to the three functions of the immune system. So to elicit the immune response. Yeah, this slide is important because tells us about the source of the B cells and T cells and how they become differentiated. So the stem cells in red bone marrow, they will give rise to the undifferentiated lymphocytes. So the bone marrow, the red bone marrow, is going to produce the lymphocytes, both B cells and the T cells. But at this point, they are not, hasn't been differentiated yet. They are not ready to elicit the immune response yet. B cells will supposed to produce antibodies, synthesize antibodies, And T cells, it has different mechanisms how to attack and how to elicit the immune response against the invading organisms or invading objects. So the T cells, so remember that T goes with T and then B with B. The T cells goes with the thymus gland. We have a small tiny thymus gland in the chest, but this one, the gland with the aging process gets smaller and smaller with the aging process. So the thymus gland is responsible for the differentiation of the T cells. So it will make the T cells an active effector T cells, ready to elicit the immune response. Bone marrow release the T cells, T lymphocytes, travels to the thymus gland. Thymus gland produce some enzymes to make it effective. So it will make the undifferentiated T cells become more differentiated and become effector T cells. Then they will travel to the lymph nodes and it will start the surveillance as an effector T cells or effector T cells. The B cells, they travel right from the bone marrow, bone marrow, and then to the blood, and then to the lymph nodes. So eventually, both the T cells and the B cells will be present in the lymph nodes, and so they start the surveillance system, and they will, produce the memory cells, and then they will start or begin or become effective and effector T cells and B cells to elicit the immune response. Either the immune response would be humoral or cell-mediated. So one example of the cell-mediated, when we inject the PPD test, it takes about 48 to 72 hours to elicit the immune response, right? That is, we have to wait. We cannot read it right away, right? So you have to wait. You can't read the PPD test once you inject it, like when we inject for, let's say, penicillin test, skin test. You will inject small amount of penicillin, very diluted, into the penicillin under the skin, and then you will wait about 10-15 minutes. So that's the time the immune response would be elicited for the penicillin versus the PPD test. That will take about 2 to 3 days. 2 to 3 days to elicit the immune response. So the cell-mediated is a delayed immune. One of the cell-mediated is called delayed immune response, and that takes time until the cell-mediated immunity would occur. The humoral response, that's when the antibodies are produced by the B cells. So the humoral response, the antibodies will be produced by the B cells, and the antibodies or immunoglobulins will have specific function, each one, like IgA, IgD. So you have you can list them as so you can remember them using the acronym GAMED, GAMED. Like IgG is the large amount of immunoglobulin now is of the type IgG, and then we have A, and then M, and E, and D. The cell-mediated immunity, that's during the immune response, the T cells will undergo differentiation and develop into several subgroups of effector T cells. And we find that we have a long list of T cells, T helper cells, T killers. We have lots of cytotoxic cells. So we need both of these cells, the B and T cells, for the immune system, for an effective immune system and healthy immune system. So we have immunity, either it's natural or it's acquired. So we know what's when it's natural. What about the acquired? Acquired can be active or passive. When it's active, acquired passive immunity, that's could be also natural or artificial. Natural, for example, acquired active natural immunity, that's when we recover from, if the baby or infant got infected with chickenpox or mumps or measles, and they recovered from the disease. That is natural. Their body able to fight the disease and produce the antibodies for that specific disease. So they became immune because they were, they had the disease and they got infected with measles, for example, recovered. So that is called acquired active natural immunity. Acquired active artificial, when we the immunizations we give to the children, or to any type of immunization, even the COVID now, we're getting COVID vaccine, that is called acquired active artificial, because we get injected with the COVID vaccine, and then our immune system is going to react to produce the antibodies, and that is exactly what you call it for this COVID vaccine. And acquired passive, that's going to, so we always encourage, or wish that we always have that acquired immunity in terms of to be active, not passive, because the active it lives longer, so it has type of longevity. But when it comes to the passive, we always need some boosters. So it's temporary. So we need to be revaccinated, or to get the boosters frequently. So like passive natural, acquired passive natural, that's when the an example of that, like the maternal immunoglobulin to pass to the neonate or the baby through the breastfeeding. Artificial, when it's passive artificial, when we receive the immunoglobulin intravenous, immunoglobulin, injection of immunoglobulin, that will be an example of acquired passive natural, artificial immunity. Now the antigens, which is the substance or particles or molecules going to elicit the immune response. So the immune reaction or immune response would be elicited. So when you inject the a person with with the COVID vaccine, that's the antigen. Even this vaccine is going to be, we could call it antigen, because it is the antigen is going to elicit the immune response. So our immune system is going to be activated to produce the antibodies. So it's the antigen, it's any substance that's going to elicit the immune response and will be recognized as non-self. Immunogen can be used as a synonym with antigen. Sometimes, some even textbooks, they will, use it as a synonym. Not all antigens are immunogens, because there are some antigens that are weak and not potent or strong enough to elicit the immune response. An example of that would be the poison ivy. It's called hapten. It's not immunogen. It's supposed to be an immunogen, an antigen that is able to elicit the immune response, called immunogen. But when in the poison ivy case, here we have something called hapten, because it's unable to elicit the immune response until it sticks to the skin, and then there will be like a more sequel of events to to explain the mechanism how the hapten, which is poison ivy, would result in the immune response. But that's an example of that not all antigens are immunogens. The antigen is supposed to be strong enough to produce the immune response. That's why there are some of the antigens that are not immunogens. So the criteria that influences the degree to which the antigen is immunogenic. So the antigen to be immunogenic is able, in other words, able to elicit the immune response, either T cells or B cells. So either one. B cells antibodies production or T cells, cytotoxic T cells, direct destruction of the antigen, so of the foreign body. So first of all, the immune system is supposed to recognize the antigen as foreign body. Otherwise, the immune response will, or I mean, the antigen will get away with the immune response and will never be attacked by the immune system. And then the actual size and the adequate chemical complexity, and all these are features or like criteria so needed for the antigen to be a strong immunogen to elicit the immune response. And we have our criteria. Now, the self-antigen, and this is when the patients develop what is called the autoimmune disease. That's when our body is going to attack its own cells. Why? Because our body or our immune system recognized our own or our cells as non-self. So that's the basic concept in the immune system and the reactions and immune responses. Once the immune system recognized the cell as non-self, regardless of that, that's foreign body or your own cells, the immune system will react to attack it. So most individuals are tolerant to their own antigens, but at some point, for some reason, and sometimes there is no explanation why patients develop the autoimmune disease, that their own immune system recognizes their own cells as non-self, and that's when the patient start to immune system to attack its own cells and results in destruction of its own cells, what is called the autoimmune disease. The lymphocytes and the T cells and the B cells, this is just the distribution and the percentage of each type in our body. We have about 70 to 80% T cells, 10 to 20% B cells, and then the null, which is like the natural killer cells, less than 10%. But most of the cells of the T cell type, most of the cells are T cells. And we said that the B cells are lymphocytes or B cells, responsible for, we call them also, the B cells also, they are called plasma cells. B cells or B lymphocytes also, they are called plasma cells, able to produce the antibodies or the immunoglobulins. The T cells, we said that they become differentiated in the thymus gland, because the thymus gland secretes some hormones like thymosin, the thymopoietin. These hormones produced from the thymus gland to stimulate the maturation of differentiated T cells. And the lymphocytes or T cells, they are responsible for the immunity to intracellular viruses, tumor cells, and fungal infections too. So two different types of immune reaction or immunity. We have the cellular immunity and the humoral immunity. The humoral, which involves the B lymphocytes, the beta cells or plasma cells, to produce the antibodies or the immunoglobulins. And we have all of them here, or most important immunoglobulins here, as from the highest to the lowest, GAMED, gamed. And we have a description for each type. Most of the initial responses to the immune system or the immune response would result in the production of large amount of immunoglobulin IgG. So, and then when the secondary attack or secondary response, then we will find more of IgM. So the immunoglobulins or the antibodies, this is the structure of the immunoglobulins or antibodies. And type A, IgA, on the bottom right lower corner of the slide. The IgA, you see that J chain, there is a specific J chain. The IgA, it's this is a type of antibodies mostly present in the bodily fluids, urine, secretion, saliva, all different types of fluids in our body. So we have lots of the IgA antibodies or immunoglobulins that present in the bodily fluids. So due to the deficiency of this immunoglobulin, we anticipate the patient would have infections like wound infections due to the secretions or urinary tract UTIs because of this, which is the deficiency of the IgA. And the IgA, because it's present in the bodily fluids, so it attempts it's it's structured like that with the J chain to be protected from the enzymes present, which is present in the bodily fluids. These enzymes can disintegrate and can destroy the this immunoglobulin, but this J chain is to protect it from that. So it's protected from the being destroyed or being disintegrated by the bodily fluids. But the most important piece of information here, which is that the IgA is present in the bodily fluids mostly, and then its deficiency could result in, so patients with deficiency of IgA, they might be prone or at risk to develop the frequent UTIs and frequent wound infections. And the other type or the other form of the immune system is called cell-mediated immunity. And I listed here some of the functions and importance of the T cells. So the T lymphocytes or T cells, they protect against the viruses, tumors, neoplastic or neoplasm, pathogens, and also it's responsible for to develop the immune reaction or immune response of what is called the humoral immune response. And we have a long list of of T cells or different types of T cells, memory T cells, and the same thing with B cells. Also, we have memory B cells. All of these are different types. Like for HIV/AIDS, for example, the HIV, the virus, it attacks specific types of neutrophils called CD4 T helper cells. These are the cells that will be primarily attacked by the HIV virus. It will attack the T helper cells, the CD4. And that's why the patient will have a significant decline in the number of the CD4 count. And CD4 count is supposed to be between 600 up to 1200. in a healthy person. Half of that amount, I mean that count, should be of a CD8 count. If you have a 600 CD4 count, then we anticipate that that's 300 of CD8 is good. So that's expected that 2 to 1 CD4, 2 to 1 CD8 ratio, 2 to 1. In patients with HIV/AIDS, we anticipate that because of that decline in terms of that HIV is gone, or HIV, the virus, attacking the CD4 and destroying them, then they will have a significant decline in or decrease or drop in the CD4. So the ratio no longer is 2 to 1, it will be 1 to 2. So we'll try with the management or with the drugs and medications for the antiretroviral medications to maintain or at least to boost that CD4 and to stop at some to some extent the disease process by maintaining a CD4 of at least over 500 if we can, with patients' compliance with taking the meds and the regimen, so that the patient won't develop opportunistic infections. Patient with the HIV/AIDS, they will be at risk to develop the opportunistic infections when their CD4 count is less than 200. Over 500 is the optimal. That's good, and that's what we optimally or love the patient with HIV is to have a CD4 count over 500. And anytime it's less than 200, they will they will be at risk to develop the opportunistic infections. Now, what is the we said CD4 is T helper cells and CD8 is the T suppressor cells. So we need a balance between these 2 to 1 ratio, because the CD8 suppressor cells, their job is to suppress the immune system from exaggerating. Because if the immune system is going to, T helper is good, but we need also some type of cells that is going to stop the immune system from being, from going like, crazy or exaggeration. And that's what is called, if you have more of CD8, then it's going to attack your body, your cells, your own cells, which becomes like more exaggerated immune reaction or immune response. So the CD8 is going to control the immune reaction from going off or going, exceeding the limits or exceeding the expected limits. So the CD8 is to control the immune response. And here, a description of CD4 versus the CD8. Cytokines like interleukins and interferons, the ones that we mentioned earlier about the cell-mediated immunity. These are important for the presentation of the macrophage. So some of these cytokines will stimulate hematopoiesis, like patients. An example of this would be patient with renal failures. The kidneys, mainly responsible for one of the functions, is to produce the or activate the erythropoietin. It's one of these hormones, one of these cytokines, to stimulate the bone marrow to produce red blood cells. So the patients with renal failures, they will have problem with producing this erythropoietin, this type of hormone. So it will result in severe anemia. So that explains why patients with end-stage disease or renal failure they will have, or CKD, they will be anemic, severely anemic, because of this cytokine or this hormone that they don't have enough of the erythropoietin to stimulate the bone marrow to produce RBCs. So the immune response is the first exposure to the immunogen or the antigen or immunogen is to elicit the primary response. And later on, and then, so at this point, there will be memory cells floating, surveilling, present in the lymphatic fluid and able to identify the antigen in the future. So anytime we are going to be exposed or this antigen will be present or immunogen, then we have the memory cells readily available. Is going to elicit that immune reaction or immune response. So the primary immune response, we will have IgM and IgG. But in the secondary exposure or the secondary response, next time, like when we are exposed to the same, when we have the same immunogen, then the IgG will be extremely high. So there's the response will be more rapid, and the secondary immune response will be more rapid than the primary one, and we will have more and large amounts of the IgG, immunoglobulin type G. The IgM will be produced in similar quantities to the primary response, but the IgG is produced in large amounts in the secondary response. So that's why the secondary response will be more heightened and more intense and more rapid and also more heightened and intense. Okay, so we got 5 minutes left. Let's just do these questions and then I will continue, next week for the rest of the chapter. So who wants to take the first question?
I'll take it.
Go ahead.
Which of the following best describes foreign or non-self substances as antigen?
Good.
I'll
Next.
take the second. Which of the following terms describe the type of immunity that occurs when performed antibodies transfer from donor to recipient? I would say passive immunity.
Mm-hmm. Next.
Both B and T cells are originally derived from cells of from bone marrow?
Yes. Mm-hmm. Yeah. Yeah, lymph nodes, no. Thymus, no, because lymph nodes, they are responsible for, both T and B cells, they will be differentiated, will go to, once they are differentiated, they will travel to the lymph node and lymphatic fluid, and then they will reside there and live for the rest of their life. For thymus gland, it's just responsible for the differentiation of the T lymphocytes, T cells, because the thymus gland produces certain hormones to make them effective T cells. Next.
A 16-year-old male is bitten by a rabid dog while jogging in the park. Upon admission to the ER, he is given
Which one would be like immediate immune reaction and or immune, like your immune, you need something that work right away, something fast effect or response. When you get the toxins, like let's say like the toxoid vaccine, like for anti-tetanus booster, you'll get immunoglobulins.
Okay.
Mm-hmm. Last one.
The immunoglobulin that crosses the placenta confers passive acquired immunity to the fetus.
Mm-hmm. Yes. All right. So the last, part of the lecture will be infection, and that will be done next week. Any questions? Questions?
Professor, I have a question, but it's not on this topic about the accreditation